There are two short topics, diabetes insipidus and SIADH. Both of these are complications. They do not exist by themselves, meaning once the patient gets this diagnosis, your next question will be what caused it? Okay, because the treatment will be, of course, we treat the underlying cause, what led to the disorder. So these are two opposites. We have diabetes insipidus and SIADH, which is syndrome of inappropriate antidiuretic hormone. Now, even though the name here suggests diabetes, this has nothing to do with blood sugar. It is an endocrine disorder, just like diabetes mellitus. However, this one is a antidiuretic hormone deficiency problem. There are three forms of diabetes insipidus. It can be primary, can be secondary, it can also be nephrogenic. In any case, whether it's primary, secondary, or nephrogenic, the patient has decreased not enough antidiuretic hormone. Okay, so and again, let's review. Antidiuretic hormone is produced by the hypothalamus. However, it's controlled by the pituitary gland. Okay, its action is simply on water. It has no direct effect on sodium. However, indirectly, because as a result here, you don't have enough antidiuretic hormone. So during emergency episodes wherein you need it, you don't have it. As a result, the patient excretes large volumes of dilute urine. Okay, so let's look at the causes again. So usual cause is head trauma. Now, don't be restricted when we say head trauma. It's not just somebody falling from the ladder or getting into a car accident. Trauma also involves brain surgery, correct? Or hemorrhagic stroke or stroke itself. All of those indicate the patient had some sort of trauma, meaning some sort of injury or lack of blood flow to one or more parts of the brain. All right. So all of those constitute head trauma, which can cause diabetes insipidus. Some rare cases can be idiopathic, meaning we have no idea what's causing the patient's diabetes insipidus, but that's quite rare. Most of the time, we can pinpoint the exact cause. Okay, so most cases we can see, oh, patient had a stroke or patient has some brain tumor, for instance. That can always, meaning something injured the hypothalamus or the pituitary gland, because it's either one of those that gets injured, which are they're in the brain, right? So any of those injured by any of these, or let's say stroke, I mentioned stroke, which is a cerebrovascular disease, right? Can cause diabetes insipidus. The nephrogenic is kind of different because this one, the patient may have adequate antidiuretic hormone, but then the kidneys don't respond to it. Okay. Or it can also be secondary, which is secondary means it's caused by something else, usually drug induced. Like lithium is very notorious for causing diabetes insipidus. Manifestations. So this patient, in all respects, the patient is dehydrated because they pee so much. I had one high school friend who had it, and she was carrying jugs of water when she goes around. Okay, so hers was she had some type of a small brain tumor that was what triggered her diabetes insipidus. So it's not permanent. Okay, so she got treatment, she got chemo, radiation, surgery, and then the DI went away. But if you look at this patient, they're dehydrated. So heart rate high, blood pressure is low, BUN creatinine high. The only exception is in the urine, because if the patient is peeing a lot, what does the urine look like? Which is opposite, right? It's like what do you call that term? It's what's the term? Yeah, another term for that. It's no, the term.
Triggering.
Not synergy. Which is dilute, place.
It'll come back to me. Okay. 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 Anyway, so the patient who's dehydrated is supposed to have concentrated urine, correct? This one, they do not. The patient's urine here looks like they're in fluid overload because it looks diluted. It has a low specific gravity, okay, which is opposite, right? It's supposed to be high specific gravity and very concentrated if you're dehydrated, but no, not in this particular example. Okay, so this is just one exception, right? So don't be so come exam one, don't be distracted by that. Okay, because again, this patient, when you look at them, all other labs, they look dehydrated. Okay, as with anybody else who's losing so much fluid. Okay, they're dehydrated, however, the urine is different. Okay, the urine looks like they're in fluid overload. Treatment. Oh, the sodium here will be high, not because they took a lot of sodium, but because of the severe dehydration. So there is hypernatremia as a result of loss of blood volume. So they lost so much water that the sodium levels rise. For diagnostic testing, I already mentioned, the urine will look different. Okay, specific gravity will be low. Concentration or osmolarity will also be low. And of course, the sodium levels will be high. Treatment. Of course, we need to treat the underlying cause, but since not all causes, let's say stroke, is that easy to treat? Not really, right? Head trauma. So therefore, treatment will be based on what's the nature of the disorder again? What does the patient doesn't have enough of? Antidiuretic hormone. So we will give them the antidiuretic hormone. It comes in a drug called desmopressin. Now it comes in a vial. No, sorry, it comes in an ampule. So therefore, you have to draw it with a filter needle. Okay, so when the pharmacy sends it up to you, it will come with a filter needle, unless if you have filter needles already in your medroom, which not all hospitals have that. But anyway, so they send you the ampule, and then it'll come with the filter needle. The other treatments, the other drugs here are for supportive purpose only. Let's say vasopressin, for instance, vasoconstrictor. So this will help increase blood pressure. So there's symptomatic treatment to maintain perfusion, maintain blood pressure. And of course, we give the patient lots of fluids. So if they're still conscious, we give it by mouth, but not likely, right? Because can you drink 1 liter per hour? No. So it's gonna have to be IV. If it's nephrogenic, then these are the drugs that will be avoided: thiazide diuretics, prostaglandin inhibitors like indomethacin and aspirin. Aspirin is just one NSAID. So basically all NSAIDs are prostaglandin inhibitors. So this will include also, so these are two NSAIDs, indomethacin and aspirin. So we've got ibuprofen as well. So those are also prostaglandin inhibitors. Nursing management, because this is a fluid deficit patient, right? So same as we discussed last week. So you weigh the patient daily, check vital signs, check labs. That's it. Any questions? Let's go straight to the opposite problem, SIADH. So similar to DI, this one, the causes are also similar. These are the known culprits for causing SIADH: brain surgery, head injury, infection, meaning brain infection like meningitis, for instance. So these are all known causes for SIADH. Cancer is also a known trigger, as well as cancer treatment. So when we discuss chemotherapy next week, this will be mentioned again as one of the complications. Okay. So this is opposite. So if we didn't have enough ADH and diabetes insipidus, this patient has way too much. Both, by the way, the diabetes insipidus and SIADH are emergencies, meaning what could possibly happen if you have way too much antidiuretic hormone? What could kill you? Fluid overload, especially heart failure. So you go into acute pulmonary edema, severe heart failure, and then death will follow. Okay. So this is an emergency, right? In fact, this is one of the 6 oncologic emergencies, meaning cancer emergencies. Treatment, it's self-limiting. However, since the patient really when the patient has a severe case, of course, we have to treat acute pulmonary edema, correct? Which is acute heart failure. So on top of restriction of fluids, this patient also, by the way, has symptomatic hyponatremia. Because of the large amounts of water being reabsorbed, the sodium levels drop dramatically, causing cerebral edema. So these patients can go into seizures, right? So we need to treat the sodium levels here, because it's not like they lost the sodium. Sodium's still in the body. However, because of the severe fluid overload, the massive reabsorption of water, and therefore what would happen to this patient's urine output if they're reabsorbing too much water? Okay, they'll go oliguric or even anuric. So we restrict fluids and then give the patient diuretics, and then we'll treat you remember the Vaptan drugs last week, Tolvaptan and Conivaptan? Yes, so we'll give those as well. Again, we can only give those drugs where? In a hospital setting, okay? Either given IV or PO. But again, because the side effect is severe hypernatremia potentially, so we only give that in admitted patient, on inpatients only. So diuretic agents, keep in mind though, diuretics, especially furosemide, yes, it will excrete water, but what will also, okay. Now, not just potassium, okay? This will also excrete sodium, okay? So be careful when you administer diuretics, okay? Because it will deplete everything. And if that's the case, a patient may, instead of diuretic, they may receive hypertonic saline instead. But also keep in mind, what's a side effect of a hypertonic solution? Fluid overload as well. So be careful as well if the doctor orders that. And just like DI or any other fluid and electrolyte case, so you monitor the same things. Weigh the patient daily, accurate INO. Please keep in mind, we have non-invasive ways to, let's say the patient is incontinent, right? So we have non-invasive ways to still measure output not hourly, but urine output through PureWick. Okay, we have PureWick, PrimaFit, meaning you don't have to put in a Foley. Okay, however, if we have really critical patients wherein we need hourly urine output, the only way to do that is with a Foley catheter. That's it.